Welcome to the Healthy Podcast presented by MelroseWakefield Healthcare. My name is Rob Branya, and I am pleased to welcome to Studio B Dr. Laurence Conway, Medical Director of the MelroseWakefield Cardiovascular Center and Assistant Professor of Medicine at Tufts University Medical School, and Dr. Ann Garlitski, Co-Director of the New England Cardiac Arrhythmia Center at Tufts Medical Center and Assistant Professor of Medicine at Tufts University School of Medicine. Thank you both for being here, and welcome to the Healthy Podcast.
Thank you, Rob.
Thank you so much for having us.
Today we're going to be discussing affairs of the heart, but more specifically, we'll talk about advanced cardiac care in the community. So let's start with the numbers. According to the American Heart Association, heart disease is the nation's #1 cause of death, killing 650,000 people every year. And this one really grabbed my attention. With the newly updated guidelines, they say that nearly half of all U.S. adults have some type of cardiovascular disease. So I think we need to define this a little bit first. So what exactly is considered cardiovascular disease?
Yeah, so thanks, Rob. It's really important. Dr. Garlitski and I know full well that cardiac disease is the most important medical problem that will impact all of our patients and our communities. Cardiac disease really encompasses all of those things which everyone knows about. I think all of our listeners will have a friend or family member or themselves who see a cardiologist or have heart disease. And it runs the gamut from, Dr. Garlitski and I see, teenagers to people well in their 90s. I have 4 patients over 100, which is a good thing. So that's hypertension, that's high cholesterol, that's inactivity, that's family history of heart disease, that's heart attack, that's stroke. Those are all the things that's congestive heart failure, and all the things that Dr. Garlitski takes care of, all the cardiac rhythm problems, which are so prevalent in our community.
And with that many people, again, half of adults in the U.S., what is the best way to treat everyone and take care of them? Understanding the differences between routine care and emergency care.
So one of the things that's really rewarding in our practice is to see patients before they develop overt heart disease. So seeing patients who come in are just worried about their heart, which is a common reason to see us. Doc, I'm worried about my heart. My dad had a heart attack at 50. What can I do about it? And those are really fun cases because you get to start before something happens. And it's a lot of things like our grandmother told us. It's getting daily exercise. It's going for a walk. If you have your Fitbit and you're counting your 10,000 steps, that's great. It's eating a healthy life, eating healthy foods, having a healthy lifestyle. And if you have other risk factors like high blood pressure, high cholesterol, we treat that very, very early so you prevent heart disease as it might happen later on.
And the other plug I would mention here is for women as well. Breast cancer, which is, of course, very important, gets a lot of publicity. It's something women are very concerned about and often screen for early and appropriately. Cardiac disease is the same thing, and women often present in atypical fashion. It's not always the same typical presentation of chest pain, chest discomfort that men have. It can be symptoms of lightheadedness, dizziness, nausea. There are a variety of different symptoms. So we're always happy to see patients take their symptoms very seriously and see if they need appropriate further testing or not.
That's great. And, I think that covers sort of the maintaining people's health. But then when it comes to more advanced care that's necessary, when we get into more emergent situations, not all community settings are equipped to handle or treat all cases. Can you talk a little bit about what differentiates between those who can handle those situations and those who can't?
Yeah, sure. So I'll take us back a little bit because I think it's important, just a little the history. So Melrose Wakefield has been an esteemed hospital for many, many years, with a long history of great healthcare. When Melrose Wakefield was thinking about finding a tertiary partner, a lot of the thought was, how do we best work with some of the academic medical centers in Boston, and what's the right relationship? And what we found is that Tufts offered something quite unique. It's called the distributed academic model. And what it means is that expert care is not just meaning that we have, critically ill or sick patients in the office or in the hospital. We're going to send them into Boston. That's what most other community hospitals do. We think about it a little different way. So Tufts, with experts like Dr. Garlitski, actually come out to our community. She was actually seeing patients today in our office. So it's something different and quite unique, and it's incredibly important to our patients. And just for a couple examples, and I'm going to turn to Dr. Garlitski, because what she does is actually quite expert, and she's a world leader in this. So I'm an interventional cardiologist, so we see patients with heart attacks, seeing them at the worst time in their lives, something that has mortality to it. You can die from a heart attack, obviously. What we've developed at Melrose Wakefield is a 24/7 seamless care, such that there are 5 tremendously trained, all Boston-trained interventional cardiologists who live within half hour of the hospital, and they're a half hour within saving your life. An outstanding team of nurses and technicians, and the idea is that we're going to get that your patient having a heart attack in to get treated all most of the time within an hour. We're proud to say that in the last 3 years that none of our patients has died from a heart attack, which is quite exceptional. We have some of the best outcomes in the surrounding Boston area. We've actually been participated in a national study of patients who are really ill. I'll talk about a little bit, who come in the worst form of heart attack, cardiogenic shock. Something that is very unique for a community hospital too. And in fact, we don't really think of ourselves as a community hospital anymore. We think of it, this is when you come into Melrose Wakefield, you come into Tufts. We offer the highest end cardiology care, we think, in our region.
Great. And to do all of that work, to treat heart attacks, you need special equipment. You need a special sort of place for all that to happen. My understanding is that ambulances can only take someone who's having a heart attack to certain places who have that equipment in place, a cardiac cath lab. Can you talk a little bit about what goes on in the cath lab?
Sure, Rob. So we have a tremendous relationship with our primary, first responders, EMTs, firefighters across our region. We have a personal relationship with them, actually, such we know their first names. They call us, text us. We have a sick patient coming in, and we're right there to greet them. The treatment of heart attack has evolved over time, and most of the time it means coming urgently to the cath lab. But usually, if you come in with a heart attack, you spend about 5 minutes or 2 minutes getting an EKG, 10 minutes in the emergency department. We have you down in the cath lab very, very quickly. The thing we measure is how quickly it takes to get a patient from the emergency room to the cath lab. That's called door to balloon time. And across the country, that standard is 90 minutes. We do ours in about 60. Once you get to the cath lab, rest assured that you're being cared for by a world-class team. All my colleagues have many, many years of experience. Most of us are 20 years trained. Most of us have done over 8,000 heart catheterizations and 4,000 angioplasties. What we've seen in the last few years is that for the sickest patients who, 3 or 4 years ago, unfortunately would have died in the cath lab because they were too far gone, they're in shock, which means their heart's so bad that it's not giving blood supply to their brain and the rest of their organs. Those patients, unfortunately, we couldn't do much for them, and some of them would die. Now that's not true. We've been able, by working with the doctors at Tufts Medical Center, offer what they offer there. We can implant these small pumps through the artery in the leg, which takes over for the heart. When someone has bypass surgery, they go on a bypass machine, this big bypass machine. Well, those are very small now. We can put them in through a catheter. So the patient goes on a bypass machine in the cath lab, rests their heart, and we've had some amazing outcomes in the last couple of years where patients who, unfortunately and sadly, would have died before they're alive today.
That's great.
That's fantastic.
One of the things that truly fascinates me about the human body is that it's this ultimate organic structure or organism, yet it runs on electric power.
That's right.
So Dr. Garlitski, as an electrophysiologist, How do you enter into the picture in all of this? And can you explain sort of what you do?
Sure. So I tell patients, as does Larry, that I'm the electrician of the heart. So I see patients for a variety of reasons. Sometimes it is for a device implant. So there are many different types of devices. They fall into two broad categories of pacemakers and defibrillators that are placed for somewhat different indications. If people have slow heart rates, then they get a pacemaker. And I do implant those here at Melrose Wakefield. If they have the concern for a fast heart rhythm or have had a life-threatening fast heart rhythm, then they may need a defibrillator. And again, that implant can be done here locally. So usually I get referred from my colleagues once they've seen either a primary care doctor or a cardiologist. I then enter the picture for consideration of this kind of therapy. The other half of what we do are procedures called ablations. Also, we have a great team here at Melrose Wakefield. The nurses are fantastic, so I don't do these procedures alone. I have a great team here, and we all work together to do ablations, which are procedures where we thread catheters from the groin into the veins, into the heart, and then actually can apply energy to short circuit, so to speak, these abnormal circuits. And what we have here are these amazing three-dimensional mapping system. So the same system that I would use at Tufts Medical Center we have here. And that allows us to create in real time a three-dimensional picture of the heart and actually look at the abnormal circuit, look at the activation. And that's also great for the patient because this helps minimize fluoroscopy, in other words, X-ray exposure. So it's a great technology that we have to offer.
That's great. From your perspective, Dr. Conway did a great job talking about from the Melrose Wakefield perspective and what it means having this great relationship. Now, from your perspective, from the Tufts Medical Center side, can you talk a little bit about what that means to you, what that means to your patients, what that means to their families? When you factor in all of the travel time and parking costs and all of the other things. Can you talk a little bit about that value?
Sure. So it may seem like small, little, everyday issues, parking, but it actually is a big deal to patients where they are seen. Today, actually, one of my patients was saying exactly that they were so happy to find out that they can be seen locally, not have to drive into Boston. It is a big deal for some of our elderly patients who may not have anyone to drive them that far, who are not comfortable taking transportation into the city. So these are small things, but really important ones on a day-to-day basis. Also, I think they feel very comfortable being in the setting here where their physicians normally are, that I'm coming to them. They know that I have a relationship with their physicians, and they feel like it's at home. They know the office. They know this hospital. So I think that's important for the patients to be comfortable.
And other things that the collaboration brings? I know you mentioned a study, for example. Are there other things that we should all know about?
Well, I think there are. I think hospitals have a look and a feel. And one thing that the relationship with Tufts has brought to Melrose Wakefield has the look and feel of a downtown academic medical center. We have cardiology fellows, so Dr. Garlitski and I are their professors. And so a key part of their training is being at Melrose Wakefield. So we have the young, aspiring, the next smart, great cardiologists are actually training with us.
The next generation.
The next generation, exactly. So I'm a little older than yours. So you're in the middle generation. But it's really fun. So it's actually the collegiality and the fun of we love Dr. Garlitski and I. We love practicing cardiology. We talk about it all the time. Truth be told, she's a good friend of mine. But we talk about our patients, and it's fun to be able to teach the residents and fellows at Melrose Wakefield. Now it's not just cardiologists, it's surgical residents. And it gives the hospital a different feel. And I can tell you, patients really notice it. They feel like they're in a, exciting, burgeoning hospital. It's like a downtown medical center. Dr. Garlitski and I have been friends for a long time. We've been at Tufts together for a long time. So on Thursdays, I'm actually doing interventional cardiology at Tufts, and she shares or uses my office. So
I clean his office.
On Wednesday nights, I have to make sure, oh my God, I have to clean it before she comes. She'll kill me if it's messy the next day. We the two of us have a lot of fun taking care of patients. I think I know this is true. I mean, I love sharing patients with her because my patients get the best care and that they're seeing one of the nicest people I know.
And I think our patients sense that everyone's very collegial because they know that their care is integrated, that their physicians are being updated immediately. There's communication.
Well, thank you both very much for being here. This was great. Dr. Laurence Conway, Medical Director of the MelroseWakefield Cardiovascular Center and Assistant Professor of Medicine at Tufts University School of Medicine. And Dr. Ann Garlitski, Co-Director of the New England Cardiac Arrhythmia Center at Tufts Medical Center and Assistant Professor of Medicine at Tufts University School of Medicine. Thank you both for being here at the Healthy Podcast.
Thank you, Rob.
Thank you very much for having us.
And if you've enjoyed this podcast or have feedback for us or want to suggest future topics, please drop us a note at community@melrosewakefield.org. The Healthy Podcast is co-produced by Melrose Wakefield Healthcare and Wakefield Community Access Television. For more information, listings of community events and lectures, or to find a doctor, visit melrosewakefield.org. All content heard on the Healthy Podcast was created for informational purposes only. This content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or qualified provider with any questions you may have regarding a medical condition.